Hello everyone, welcome back. This is Ahmad Radwan and we are the USMLE Step 2 CK channel. This is pediatric surgery here. We have done 4 surgery sessions before and now we are starting the 5th. Each session is 25 minutes as a Pomodoro, like we talked before, and we're starting the 5th one with pediatric surgery. So before we start, I would like to say just a few words here. I've been feeling down a little bit lately. But then I realized I might not be the only person who's feeling that way, and it's not the first time I do feel that way. So if you are feeling down as well, if you are not really studying well, or if whatever reason you're not doing as good as you think you should be, please don't feel down. Please do not stop. Please do not get discouraged. You can continue to do this. You can do this. You can reach the end. And the only thing that you need to do is just to keep on going, to keep on practicing, to keep on studying. This is for everything. It's not only for the USMLE or for studying or medicine. I think it's for everything in life in general. So yeah. So just don't feel down and continue on doing what you're doing. You are gonna be well. Okay, so with that out of the way, let's get started. So pediatric surgery here on page 332 on Master of the Boards USMLE Step 3. It says here the conditions that need surgery at birth. So what are these conditions, and let's get familiar with them. First, I said that congenital anomalies, they constitute the conditions that need surgery at birth. The Step 3 exam, the most important first step is to rule out other associated congenital conditions, and that's actually just before surgery. So you need to look for other congenital anomalies if you find one. There is a useful mnemonic here. It says VACTER, and it's VACTER, and stands for vertebral, anal, cardiac, tracheal, esophageal, renal, and radial constellation. You're gonna find, if you find one, you might as well look for the others, and you probably will find another. And for the anus here, we'll look for imperforation, so endotracheal or imperforated anus. We check the X-ray for vertebral and radial anomalies. We do an echo for the cardiac anomalies and a sonogram for renal anomalies. Okay, so let's start with examples here. The esophageal atresia here, and just means that the esophagus is not hollow. There is an incomplete apoptosis happening here. And how we're gonna notice this and how we're gonna diagnose how we're gonna reach the diagnosis. First, we're gonna see a child with excessive salivation shortly after birth, and he might as well have some choking spells, especially when we first feed him or her. So if you notice these two, you should think of esophageal atresia here. We confirm the diagnosis with a nasogastric tube. We insert it, and it becomes coiled in the upper chest on chest X-ray, and that's how you confirm the diagnosis. We have here a basic science correlate. It says that a ventrally displaced location of the notochord in an embryo can lead to a failure of apoptosis in the developing foregut and cause esophageal atresia. So this is it gives us the embryonic origin of esophageal atresia, of why it might happen. So to have the esophagus, actually, you have to have some apoptosis, or the cells have to be to commit suicide or to be killed in the middle of the esophagus, and when this happens, you have a hollow tube later on as the esophagus. And if we do not have this apoptosis, we're going to have cells that are interrupting the esophageal emptiness, or the esophageal tube here. And this happens when the notochord location is displayed ventrally. So we can read this statement backwards, and it kind of makes sense more. Okay, so we have diagnosed that patient. How are we going to treat it? The treatment is just surgical repair. It's going to be primary surgical repair is indicated. If for some reason we are not able to do this, and we need to do sometimes further workup or anything like that, we should perform gastrostomy, and this is to protect the lungs from acid reflux, and we do not want to have chemical pneumonitis for a patient like that. So that's important. Okay, so now we're done with esophageal atresia. Let's look at the other end of the spectrum. I'm sorry, no pun intended here, but anal atresia. Okay. Okay, and so anal atresia or atresia, this is indicated by an absence of lattice or stool. Makes sense, and the anal gland is absent on the exam. So those two things, it would indicate anal atresia. We treat as follows. We look for a fistula. So this is how we do it. We look for a fistula nearby when we see anal atresia. So it could be a vaginal one or a perineum one. If we see or if we find a fistula, we delay the repair until further growth. So if the patient can grow more, but this is before toilet training, okay? So he can actually he can have a way that the stool can come out. And if it's not present, a colostomy is needed for to be done, and this is for high rectal pouches. This is really important. Okay, all right. So if we have a fistula, we delay the repair. If not, we need to do a colostomy. Okay. Now we're done with the anal atresia and esophageal atresia. Let's look at congenital diaphragmatic hernia. It presents as dyspnea, and it's going to be dyspnea noted at birth. And loops of bowel in the left chest are seen in X-ray. So a dyspneic child or dyspneic newborn, you do a chest X-ray, and you're going to see loops of bowel on the X-ray. The primary abnormality is the hypoplastic lung with fetal type circulation. So a premature might have this more than others. So if the primary abnormality is hypoplastic lung with the fetal type circulation. We have here a basic signs correlate. It says here that left-sided hernias allow herniation of the intra-abdominal organs into the thoracic cavity, while the right-sided hernias allow the liver to herniate. So a left-sided one, we should look at the intra-abdominal organs. Right-sided, liver. Okay. How are we going to treat it? Well, we treat by performing endotracheal intubation. That's first. We have low pressure ventilation sedation and nasogastric suction. We delay the repair 2 to 3 days to allow lung maturation. So basically just let the lung mature. So endotracheal intubation, low pressure ventilation, and sedation, nasogastric suction. So he wouldn't aspirate. All right. Now we have two things here that are kind of like a spectrum. We have a gastroschisis and omphalocele. So the gastroschisis here is the umbilical cord. That's normal. It reaches the baby, and the defect is to the right of the cord, okay, where there is no protective membrane and the bowel looks angry and mated. Okay, so that's it. I would like to just jump right away to the omphalocele here to kind of have a comparison that the umbilical cord goes to the defect itself. So and that's the first difference here. The umbilical cord on the gastroschisis, it just reaches the baby, it's fine, nothing wrong with it. But here the umbilical cord, it goes to the defect, which has a thin membrane under which one can see normal looking bowel and a little slice of liver as well. So this is just a membrane, and it has the intact and fine looking or normal looking bowel and slice of liver as well, but the gastroschisis here, it's going to be right of the cord, and the cord is going to be normal, but there is no protective membrane and the bowel looks angry and mated. Okay, so these are the two differences here. We have two or three actually basic science correlates that we need to know. The first one is incomplete fusion during the 4th week of the development results in the defect that allows abdominal viscera to protrude through the anterior body wall, which are the two diseases or the two anomalies that we see here. And it says here also that this is made when the lateral body fold move ventrally and fuse in the midline. So when this does not happen, or the incomplete fusion does not, happens in the 4th week, the result is either the gastroschisis or the omphalocele here. Okay, so gastroschisis it occurs when the neural crest fails to migrate. Neural crest cells really important. If you have done step 1 you would know the multiple things that can happen if the neural crest cells do not migrate, and this is one of them, gastroschisis. This results in the absence of enteric neurons within the mesenteric plexus and submucosal plexus. So this is the difference. Gastroschisis, neural crest cells do not migrate. Excuse me. The third basic signs correlate here. It says that Edwards syndrome, which is trisomy 18, and Patau syndrome, trisomy 13, are associated with omphalocele. So, omphalocele, remember that it could be trisomy 18 or trisomy 13, Edwards and Patau syndrome, respectively. Okay, so we see a patient who has either gastroschisis or omphalocele. How are we going to treat it? First, a small defect, we just close the small defects primarily. If it's a large defect, we can't really do that right away. It can't really accommodate the bowel, so this requires a celastic or silo to protect the bowel. This is important. And then manual replacement of the bowel daily until complete closure, just 1 day at a time. And this is going to take like 1 week. In the meantime, we give parenteral nutrition and IV antibiotics. Okay? So, again, small defect, large defect. If it's a small one, just replace it, just do a primary closure. If it's a large one, these require a celastic, again, a silo or something to protect the bowel, and then manual replacement of the bowel daily until complete closure, and that's going to take like a week, okay? And we give parenteral nutrition and IV antibiotics. Okay, awesome. Exstrophy of the urinary bladder, that's another one here, and this is an abdominal wall defect over the pubis. It says here that we transfer the patient to a specialized center that offers surgical repair in the first 1 to 2 days of life. We should not delay surgery, okay? Really important. So if the urinary bladder here is protruding and this is an abdominal wall defect, as we said, of the pubis, we transfer the patient to a specialized center that offers surgical repair in the first day or 2 days in life, and we do not delay surgery. A question here that says that a newborn is vomiting greenish liquid material. A double bubble is seen on the x-ray. And what is the diagnosis here? It says here A, annual pancreas, B, congenital diaphragmatic hernia, C, gastroschisis, D, imperforated anus, and E, intestinal atresia. And this is an easy question. If you see a double bubble, that's kind of like a buzzword for the annual pancreas, and the answer is yes, it's A. It says here, do not be fooled into thinking that only duodenal atresia presents with a double bubble sign. An annual pancreas and malrotation also presents with a double bubble sign. All of these anomalies require surgical correction, of course, but malrotation is the most dangerous one because the bowel can twist on itself, cut off the blood supply, and become necrotic. So this is an important question, and a buzzword like bubble should make you think about this. Okay, now let's move on to intestinal atresia here, and in intestinal atresia, it's kind of like an annular pancreas. This condition presents with green vomiting again, but instead of the double bubble, there are multiple airflow levels throughout the abdomen. So just basically kind of like an abdominal. Abdominal what? I can't remember. Okay, the abdominal blockage thing, I just can't remember. Okay, well anyways, we're going to see multiple air fluid levels throughout the abdomen here. So there is no need to suspect other congenital anomalies in this case because this condition results from a vascular accident in utero. So intestinal atresia, it's a vascular problem. It's not an enteric problem here. So we shouldn't really look for other diseases or any congenital anomalies. Okay, so it's not part of the vector. Not part of the vector. Okay. So we are done basically with pediatric surgery conditions that need surgery at birth, and now we continue with pediatric surgery with surgical conditions in the first 2 months of life. Okay. The first off, we start with the necrotizing enterocolitis. This shows up as feeding intolerance in premature infants. So an infant who is premature, that's going to be in the stem of the question, and he's going to have feeding intolerance. He can't really feed well. And when they are first fed, there is abdominal distension and is a rapidly dropping platelet count. In baby, this is a sign of sepsis. So in necrotizing enterocolitis here, again, feeding intolerance in premature infants, it's going to be abdominal distension and rapidly dropping platelet count. So in babies, rapidly dropping platelet counts it is a sign of sepsis. That's kind of new to me, actually. Didn't know that. And basic signs correlate here. It says that the most common pathogen in necrotizing enterocolitis is the E. coli and Klebsiella pneumonia. So a gram-negative here, Klebsiella pneumonia and E. coli. How we're going to treat that patient? First, we're going to stop the feeding. That's important. And the second one is to prescribe broad-spectrum antibiotics. Of course, this is necrotizing enterocolitis. And we deliver IV fluids and nutrition. We do the surgery if there are signs of necrosis or perforation, like abdominal wall erythema, portovein gas, or gas in the bowel wall. So surgery is done if there is necrosis or perforation. Otherwise, stop feeding, broad spectrum antibiotics, IV fluids, and nutrition. Okay. Awesome. Now the second thing, very famous disease here, the meconium ileus. The symptoms here are feeding intolerance again and bilious vomiting. So in a baby with a cystic fibrosis here, we look for cystic fibrosis in the family history, and I am just scrutinize that family history and see if we find any cystic fibrosis in the family. If there is, we should suspect that there is cystic fibrosis in that patient, and he has feeding intolerance and bilious vomiting. A basic signs correlate here is that it says that cystic fibrosis, which is an autosomal recessive disease, it results from a point mutation at the position 508 of the CFTR gene. Okay, that causes the mistranslation of the phenylalanine. Okay, all right. So again, cystic fibrosis, autosomal recessive, point mutation at position 508 at the CFTR gene, and that causes mistranslation of the phenylalanine. How are we going to diagnose meconium ileus here, you say? We're going to diagnose it by x-rays, which show multiple dilated loops of small bowel and a ground glass appearance in the lower abdomen. Ground glass, that the famous sign that we see here, is going to be in the lower abdomen, the multiple dilated loops of small bowel. We can do a gastrography enema. It can be as diagnostic one. We're going to see microcolon and inspissated pellets of meconium and the terminal ileum. We're going to see the meconium there. And it can be therapeutic as well, because gastrography draws fluids in and dissolves the pellets. So it's not going to be stuck there. So we diagnose with x-rays. We can do a gastrography enema to diagnose and do the therapy. Okay, so we did necrotizing enterocolitis and meconium ileus. Now let's move off to hypertrophic pyloric stenosis. That is a very important disease, I think, and it shows up on multiple occasions in children in the first 2 months of life. So this is going to show up as a non-bilious projectile vomiting. We said bilious, or it has bile in it in meconium ileus. That's very important, and that just means that it is above the level where we can actually get bile into the vomiting. So that makes sense. No bile, and it's going to be projectile vomiting after each feeding in approximately 3 weeks of age. We look for a gastric peristaltic waves and palpable olive-sized mass in the right upper quadrant. That's where the stomach is. And we diagnose with a sonogram, really easy. The treatment is going to first, we're going to correct the dehydration. So do not go surgery right away. You should correct the dehydration first and associated hypochloremic, hypokalemic metabolic alkalosis. And vomiting, it causes alkalosis. It causes metabolic alkalosis because we're losing a lot of losing a lot of acid here, and yeah, and hypokalemia because we're losing a lot of potassium as well. Well, when we do this and the patient is stable, we follow with a pyloromyotomy where we cut the muscles on the pyloric end of the stomach. Okay, so we're done with the hypertrophic pyloric stenosis. A biliary atresia follows here. So in the biliary atresia, this appears in 6 to 8 weeks. We said 3 weeks in hypertrophic pyloric stenosis. Here it takes 6 to 8 weeks, so approximately 1.5 to 2 months old babies. They have persistent, progressively increasing jaundice, and it's going to be conjugated bilirubin, okay, or conjugated bilirubin. And the diagnosis is going to be to conduct the serologies and sweat test to rule out other problems. A sweat test for the cystic fibrosis, I think, and serology for other diseases that will cause increasing jaundice here. We ordered a HIDA scan after 1 week of phenobarbital. And if no bile reaches the duodenum, even with phenobarbital stimulation, we do a surgical exploration to see what is going on and they fix it. So we do the serologies, we do a sweat test, we do a HIDA scan for after 1 week of phenobarbital, and if we do not see any bile reaching the duodenum, we do a surgical exploration right away. Okay, the last disease here that we see in the first 2 months of life, it's going to be Hirschsprung disease. I have a friend who is a pediatric surgeon, and he says that he saw a lot of Hirschsprung disease this year. I don't know why, but this trivial information might help you remember in one way or another. It says here that the most important clue to diagnose is chronic constipation. A rectal exam may lead to explosive expulsion of stool and flatus with relief of the abdominal distension. So you can do that, and if this happens, suspect Hirschsprung disease, and we diagnose it only with a full thickness biopsy of the rectal mucosa. And it doesn't say here the treatment, but I think the treatment is to remove that aganglionic part of the colon, and that should fix it. Okay, so now we're done with the surgical conditions in the first 2 months of life, and we are starting the surgical conditions later in infancy. We're going to see here intersusception and Meckel diverticulum. So those two are the ones that we see later in infancy, or the ones that master the boards right here down. So in intersusception, this is going to be in 6 to 12 months old babies, and we're going to see a chubby, healthy-looking kids with a brief episode of colicky abdominal pain that makes them double up and squat. Okay, so 6 to 12 months, chubby, healthy-looking kids, brief episodes of colicky abdominal pain, and then a double bubble and squat. We're going to see also a vague mass on the right side of the abdomen. So on the right side, remember that, I'm going to see empty right lower quadrant and current jelly stools. What we're going to do if we see these signs here, we're going to do a barium or air enema, and this is going to be diagnostic and at the same time therapeutic, so because we can clear the intersusception with that. And we perform the surgery if the enema fails to fuse to the reduction. So an intersusception actually basically it's kind of like having a sock in front inside itself. So this is kind of how you would imagine the intersusception, and again, it would be in a 6 to 12 months chubby, healthy-looking kids with a brief episode of colicky abdominal pain. We do a barium or air enema, and this is going to diagnose the problem and at the same time treat it. If not, we should do a surgery to prevent any complications. Okay. How about Mickel diverticulum? Diverticulum is different. Diverticulum is kind of like outpouching from from the bowels, and this presents as lower GI bleeding in a child of pediatric age. I can't really remember if this is the most common cause or not, but it generally presents as lower GI bleeding at the pediatric age. Here we have a basic science correlate. It says that Meckel diverticulum is a true diverticulum, and it consists of all three layers of the bowel wall. It has a mucosa, submucosa, and muscularis proper. This is actually important because we have a false diverticulum or pseudodiverticulum. We might see later on, and this is different. It's just the muscularis propria, or I'm sorry, the mucosa or something like that. So it doesn't have all three layers. In Meckel diverticulum, we have all three layers. The diagnosis here is going to be with a radioisotope scan, which looks for gastric mucosa in the lower abdomen, and we can see the outpouching, and we can do a surgical resection as the best therapy. All right, so that's been it. We actually did the whole thing. We did the pediatric surgery, which is awesome. That's 7 pages, and that's really good. Next up, we're going to do orthopedics, and hopefully we can do all of it in one session. And then urology, and we're almost done, and with the vascular surgery at the end, and some patient safety. So I'm happy with that session. I hope you are too, and we're going to see you in the next session. All right, take care. Bye.